Hi, everybody. I'm Karen Dean, the Member Support Coordinator here at Ashby Village, and I'm very pleased to welcome each of you to our Spring Healthier Aging Wellness presentation, Osteoporosis Prevention and Treatment. So hopefully that's why you all are here. Ashby Village is, as you know, committed to promoting healthier aging and to support our community members to age in place for as long as possible. And we're thrilled to be able to provide important programs like this webinar free of charge for folks in the community. We're also happy to accept any donations to support our efforts for more programming and Ashby Village generally. So Jessica's going to put that donation link in our chat box for anyone who would like to use it. Please feel free. And as we know, today's webinar is on osteoporosis. It's a collaboration with Kaiser Permanente, and we're very fortunate to have the opportunity to hear from Dr. Morali Sharma and Dr. Janet A Lai. Dr. Sharma is an associate professor at Kaiser Permanente Bernard J Tyson School of Medicine and a practicing physician who treats patients with osteoporosis. Additionally, she educates primary care physicians about osteoporosis. She's been at Kaiser since 2017. And Dr. Lai has practiced internal medicine at Kaiser Permanente Oakland since 2005. She enjoys developing lasting connections with her patients. And in her role as one of the medical directors of outpatient quality, Dr. Lai focuses on cancer prevention, cardiovascular health, and other aspects of a healthy lifestyle. Their presentation is going to be about 30 minutes, at which time I ask that folks hold your questions. We're going to have about 20 minutes of question and answer after they're done presenting their pieces. You can put questions in the chat. Sigrid's going to be managing that box. And I invite you to turn your attention to Drs. Lai and Sharma. Thank you.
Thank you so much, Karen. That was wonderful. So I believe we're going to have the slides up on the screen in a second. Great. So as Karen mentioned, I am a primary care doctor here at Kaiser Oakland, and I've been practicing for the past 17 years. And part of my role, in addition to seeing patients, is working on with our specialists and our primary care docs on certain quality topics. And for us, osteoporosis and fracture prevention is very important. We can see the lifelong implications after someone has suffered a fracture. And so really, in partnering with my endocrinology folks, we're hoping that today this talk will be valuable to you. Next slide. So this is a diagram showing what happens to a lot of people as we age. It's called kyphosis, and it's when the head starts, moving forward, the spine starts bending forward as well. And we call this kyphosis. So there is a loss of height that can happen as we get older, and sometimes this can be a sign of osteoporosis. Next slide. So today, with my colleague, Dr. Sharma, we're going to be talking about a couple things. We're going to start with the basics of osteoporosis. We'll talk about general prevention techniques, treatment, and then discussing fall prevention. And then we also have some resources that we would love to share with you as well. Next slide. And then if you don't mind hitting it a couple times, thank you. So this is a diagram of what osteoporosis looks like. And on the left-hand side, you can see normal bone. On the right-hand side, you can see that there are what we call microfractures, or small fractures that develop within the bone. And when this thinning of the bone happens, that can put one at risk for developing a fracture. So sometimes these microfractures happen before a person suffers a fracture. Next slide. And so I also wanted to touch upon the clinical diagnosis of what osteoporosis is and what medical professionals use. So when a person gets a bone mineral density, which is a 15-minute test, it's done to assess the bone, how dense or how strong the bones are. They usually look at the lumbar spine, so the low back, and also the left hip. And in looking at these two areas where we're looking at something called a T-score. The T-score is how one's bone appears compared to someone of a younger age, and in this case, usually someone in their 40s. And so we're comparing a person's T-score, their bone mineral density score, to someone who's younger. And so a normal bone mineral density T-score is something that's described as negative 1.0 or higher. And osteopenia is when that score is negative 1.0 to negative 2.5. Or less than negative 2.5. And osteopenia is the stage before osteoporosis. And not everyone who has osteopenia develops into the next stage, which is osteoporosis, but the clinical definition would be a T-score of negative 2.5 or less. And so that's going by numbers, just strictly numbers on a bone mineral density. However, the clinical diagnosis of fracture, and this is something I've learned from my endocrinology colleagues, is that a fragility fracture is when you have a fracture that happens from a standing height or less. So you could fall while hiking or trip over something, and if you're from standing height or less and you fracture a bone and you're of a certain age, usually we use like 65 and up, then that's considered a fragility fracture. There are some fractures that are not considered fragility fractures. So these would be things like a skull fracture or a fracture of the toes or fingers. But any other fracture is pretty much considered a diagnosis of osteoporosis. Next slide. And so this slide shows some of the factors that are important to talk about that are risk factors for developing osteoporosis. So definitely age is one. Women 65 and up and men 70 and up, that's considered a risk factor. Caucasian or Asian background is also an important factor. Someone who's thin or small boned or has a low body weight, someone who's suffered fractures before, and usually someone who has a first degree relative with a history of osteopenia or osteoporosis. There are some medications such as Prilosec or omeprazole that can, if you're taking it over a long period of time, like years, that can also put you at risk for a fracture. So there are certain medications that can do that. People who are not very active or aren't able to be as active, that is also a risk factor. And then hormones too. So in men, a low testosterone level, or in women, a low estrogen level, both of which can happen later in life. Smoking and excessive use of alcohol, these are other risk factors as well. Next slide. And so one of the ways that you can help to prevent this from happening is by getting enough weight-bearing exercise. So anything where your foot impacts the ground is considered weight-bearing exercise. Using weights or light weights, that's also considered weight-bearing as well. And we're pretty much instructing folks to think about at least 30 minutes most days of the week. Calcium and vitamin D are also very important in helping to build up your bones. Even if you're past menopause or of an older age, it's still important to get enough calcium and vitamin D. Usually the calcium intake that we recommend is anywhere from 1,000 to 1,500 milligrams daily. And then the vitamin D is anywhere from 1,000 to 2,000 units daily. And that's counting everything including what you're consuming in your diet, in addition to supplements. And one thing that I tell my patients is, your body can only absorb a certain amount at a time. So, for example, it doesn't help to have 3 glasses of milk in the morning. Your body will just excrete out the excess. So your body can pretty much absorb about 500 to 600 milligrams at one time. And that's what I usually recommend if a person is taking calcium supplements, to take 1 in the morning and 1 in the evening, or supplement with the diet at a later stage. Vitamin D allows your bones to absorb calcium, and that you can get from a lot of different foods and supplements. Sunshine is also an important source of vitamin D, but in moderation. Usually I tell my patients about, 5-10 minutes of sunlight without protection. And I think Dr. Sharma is going to take the next slides. You can go ahead and advance to the next one. Thank you.
Everyone, and thank you for joining. And thank you, Janet, for that nice overview. So just to continue the calcium and vitamin D replacement, these are the general guidelines. So as we get older, we tend to break down more bone. So we need higher amount of calcium, and to absorb that, we need vitamin D. So these are the general guidelines. Vitamin D requirements can vary. So it would be a good idea to once in a while check a vitamin D level, because some people may require more than 2,000 international units per day. So if the level is still lower than the normal limit, which is around 20, then yeah, they may need higher dose. So next slide, please. So how do we get calcium from our diet? So as you can see, there are several products that can give you calcium. So foods as well as drinks. And as we know, all the dairy products give us calcium, but some people have lactose intolerance and cannot tolerate any dairy products. So other rich sources of calcium are tofu with calcium, or even some non-dairy milks have a significant amount of calcium. So overall, if you're taking at least 3 or 4 servings of these foods with calcium, you don't need calcium supplement. But most of us don't quite get there. So it's a good idea to take 500 or 1,000 milligrams per day. And you can calculate your own intake based on these values and the information. Next slide. So why is osteoporosis so important? Because osteoporosis can lead to fracture, which causes a disaster, right? Anyone who's had a fracture knows how bad it can be. So, and it is very common. So 1 in 2 women and 1 in 4 or 5 men will have an osteoporotic fracture in his or her lifetime. So this is a global problem, and it has a very high impact on people's quality of life. So that's why it's very important to diagnose osteoporosis and prevent a fracture. So because of the patients who had a hip fracture, 20 to 40% can die within 1 year, is what the data shows. And 40% remain unable to walk independently even a year or so after their fracture. So this is a big problem. Similarly, so the 2 major fractures we focus on are a hip fracture and a vertebral fracture, which is in your spine. So if there is a vertebral fracture, yeah, it can cause significant pain, loss of mobility. Some patients have abdominal pressure. And sometimes because of the pain, they cannot breathe very well, and that can lead to lung problems. So overall, the quality of life can be significantly impacted. So that's why it's important to address this issue. Next slide, please. So what is the goal of treatment? We know that this is important to treat, but we cannot cure osteoporosis. Just like high blood pressure or diabetes, we can control it, and we can give the right treatment to have a benefit on the bone health, but we cannot prevent fracture, but we can certainly reduce the risk of fracture. So, because as we age, the normal process of aging causes some bone loss, which can be about 1 to 2% per year. And that is usually exacerbated, especially in women after menopause and in men after age 70. So as we lose more bone, the risk of breaking the bone increases. Next slide, please. So how do we know that the treatment is working? So now we know that treatment is important to reduce the fracture risk. So if you take treatment, you're almost half as likely to break the bone versus not taking any treatment. So while on treatment, if you don't have a fracture, that's success. And then we measure bone density to see if it is stable or improving. That's also encouraging that the treatment is working. Now, how long should we treat? It depends on individual patient. General guideline for osteoporosis treatment is to treat for 5 years and then give the patient a drug holiday and just monitor the bone density. Unless the patient has had multiple fractures, they are very high risk for fracture because they keep falling, in which case it would be okay to continue treatment for longer than 5 years. Next slide, please. Next slide, please. Thank you. So how should we treat osteoporosis? We know that we want to prevent a fracture. So there are non-medication or non-prescription medication treatments, and then there are prescription medications. So we already talked about calcium and vitamin D, which is very important for bone health when you have osteoporosis, or even for prevention of osteoporosis, right? Exercise is important because exercise can help fall prevention, because the stronger your muscles are, better your balance is, you're less likely to fall. And then, so we can also focus on fall risk reduction, which I'll get to in a few minutes. And then, because we know that smoking and excessive alcohol use is a risk factor, we would try to minimize that. And certain medications, especially steroids, can cause osteoporosis, but there are some patients which require long-term steroid treatment for other medical conditions. So for those patients, especially, it's important to closely monitor them for their risk of osteoporosis and treat as appropriate. So what about medications? So yeah, we all watch TV and they keep showing different drugs for osteoporosis to prevent fracture and things like that. So the oldest and the most commonly used medications are a class of drugs called bisphosphonates, and they are oral drugs, and there's one intravenous drug as well. So bisphosphonates are Fosamax, which is a pill once a week, Actonel or Boniva, which are pills once a month. And so the generic for Fosamax is called alendronate, Actonel is called risedronate, and Boniva is called ibandronate. So the most common side effect of these drugs is acid reflux. Some patients just won't tolerate it. And if that happens, then we switch to the intravenous drug called zoledronic acid, or Reclast is the brand, which is given intravenously once a year for 3 years, and then they get a drug holiday. So basically, these drugs act on the bone cells that are chewing up the bone. So normally there are two groups of cells that work on the bone. One group of cells is making new bone, and the other group of cells is chewing up the bone. So as we get older, we make less bone, and the cells that are chewing up our bone, called osteoclasts, become more and more active. So these drugs work on these cells and slow them down. So your bone is not getting chewed up as fast as it was before the treatment. And so the bone gradually gets stronger and is less likely to break. The other medication that we sometimes use is called Evista or raloxifene, which is the generic name, which acts like estrogen on the bone, but it does not have any effect on the uterus or the breast. So it can help improve the bone density of the spine, but it does not work much on the hip bone. The injection Prolia or denosumab also works on these osteoclasts and stops them from chewing the bone. And it's given once every 6 months. But the thing is, if you start the medication, you cannot stop it, because if you stop it, the cells that are chewing the bone become more active, can actually lead to some fractures. So, but it's been shown to be safe enough to treat for 10 years, sometimes longer. But we always have to evaluate a patient individually if they are the right candidate for a certain medication. And teriparatide or Forteo is a daily injection, which works differently, where it helps actually make new bone. So it's approved for treatment for 2 years. And after that, it needs to be followed up by another 2 or 3 years of a bisphosphonate, because otherwise you lose that new bone that's formed by teriparatide injection. Estrogen and calcitonin were previously used, but estrogen is not recommended for treatment of osteoporosis because of its other negative effects, like on heart disease or breast cancer risk and things like that. So, and calcitonin does not help decrease fracture risk, so that's not recommended either. Next slide, please. So fall prevention is very important, right? Because if you don't fall, you don't break anything most of the time. But with severe osteoporosis, you can sometimes break, like especially you can have a fracture in the spine without falling down, right? So it's important to know how to prevent a fall. It's usually common sense. Next slide, please. So things that seem common sense, sometimes we don't think about. So basically, we need to clean out the clutter in our house, right? We always have things laying around. So anytime you have loose things laying around, there's a risk you can trip and fall, right? So never use a chair to climb on something. Always use a step stool. If you have stairs, make sure you have railings so that you can hold on to it. Make sure the home is well lit. Don't have any loose rugs laying around, things like that. So this is one of the resources that's available on the Kaiser website. So you can read more about it. And sometimes you know it, but you forget to do it. And then there goes the fall. So next slide, please. Next slide, please. Okay, so I think that's the end of our information we wanted to present. And we are happy to take questions that you may have. And we'll try to answer them as best as we can.
Yeah, thank you very much for that presentation, Dr. Sharma and Dr. Lai. There are quite a few questions in the chat box, and I will start right away. One question was about information about men and osteoporosis. I mean, I think most of the time you hear about women and osteoporosis, not so much about men. And people were just asking, I mean, if you could say something about that.
Yeah, I mean, men can also have osteoporosis. So general guidelines recommend that we check bone density in all women 65 and over. Now it's also recommended to check bone density in men age 70 and over as a screening bone density test. And if they do have osteoporosis, then treatment is recommended.
A general question for the two of you. I mean, the slides that you were showing, are you making them available for the participants? Would that be possible?
Yes, I can send them over to Ashby Village and you guys can distribute as needed. Sure.
Thank you. Very good. There are a lot of questions actually about specific medications and osteoporosis, but this one is more like a general question. I understand that a new test has been developed that measures bone quality as opposed to merely density. Could you please tell us more about the new test, and will Kaiser be offering this test?
I'm not sure what that new test is. Dr. Sharma, do you know?
Yeah, I think it's called trabecular bone score, or TBS, which would be measured along with the bone density test. So yeah, some centers have already started using it. We are in the process of installing that at Kaiser. I think it may be another few months, maybe a year, before we can start offering it to our patients, because it helps add another tool to evaluate bone density, because half the patients who have fractures, like hip and vertebral fractures, have normal bone density. So the question is why? Because bone density only measures bone quantity. We don't have a measure of bone quality. So this trabecular bone score, when it's widely available, will help help us evaluate the bone health a little bit more. And we can use that to guide treatment.
Okay, one question here. Can you take a larger amount of vitamin D once a week, or does that also have to be divided up the way calcium is?
Yeah, you can take vitamin D once a week. Some people even take a large dose once a month, because vitamin D is stored in the body for long term. So you don't have to take it multiple times a day. It's long, it stays in the system, and it's gradually released from the fat cells. So you can take it once a day, once a week, once a month, whichever works for you.
If you have not been taking supplements and begin now, can one rebuild bone?
Yes, yeah, you can. I mean, with weight-bearing exercise, again, where your foot's impacting the ground, aerobic exercise, walking, all of that can still help build up the bone. And we still do recommend the calcium to help build up the bone as well. Dr. Sharma, did you want to add to that at all?
So, I mean, calcium, vitamin D, and regular exercise are important for not only preventing osteoporosis, also for treating osteoporosis. So at any stage in your life, I think these three are key to your bone health. So yeah, it'll definitely prevent further deterioration of the bone, but it can also gradually help build the bone. And the osteoporosis medications are more effective when they're used in conjunction with calcium and vitamin D.
Somebody mentions boron and strontium that they have been taken for over 5 years, in addition to getting vitamin D and calcium levels up to normal. It improved the bone density into the osteopenia range from osteoporosis. So what are your thoughts about strontium and boron supplementation?
Right. I mean, I don't recommend it because, first of all, they're not available in the United States. I think in Europe, there are people who use strontium for treatment of osteoporosis. And yeah, I agree. It does improve bone density because it does work, but there are some concerns. So overall, the fracture risk reduction effect is not as great as we have with bisphosphonates. Besides, there are some concerns about side effects on the heart issues with strontium especially. So I generally don't recommend it.
Okay, what about magnesium and vitamin K2? Are they needed for calcium absorption?
Magnesium is not really needed for calcium absorption, but magnesium is important in bone health because it helps normalize the function of parathyroid hormone, which works on the bone. But overall, yeah, magnesium is important. Now, K2 is something new that's coming up, and we're still learning about it. There's not enough data to show that it's beneficial. So, but there's not enough studies done, but I'm sure there are a lot of ongoing studies. So in the near future, we'll know more how important K2 is for bone health.
There's a question about the statistics you showed. Does the statistic related to how many people die after a fracture have to do with other conditions that might have contributed to the fracture? I think the question was, or is it really purely because of the?
Yeah, so most of these studies are controlled for other factors. And despite the controlled studies, they do show that with everything else being equal, patients who have a hip fracture are more likely to die.
What do we do after a drug holiday? I've had osteoporosis since age 45 after treatment for breast cancer, and I'm now 67. I'm currently doing reclassed every couple of years for the past 7-8 years. So what do we do after the drug holiday?
So like I said, the main goal of treatment is to prevent a fracture. So if you've not had a fracture, that's success. And so sometimes continued treatment, especially if it's continued for a long time, is not good for your bone because the bones can get brittle and then you can have what's called atypical femur fracture, which is just breaking of the thigh bone right in the middle without any trauma, which can again be bad. So if it's been reported in patients who keep taking bisphosphonates for 10 years or longer can have a higher risk of this atypical femur fracture. But so general recommendation is to treat, if you have osteoporosis for bone density, to treat with reclass for 3 years and then monitor bone density every 2 to 3 years. And if the bone density goes down significantly, or if you break a bone, a major bone, then repeat treatment is indicated. But so we prefer not to treat continuously. We kind of break it down and then just monitor the bone density in the meantime and see what it looks like and then decide if continued treatment is required.
Is osteoarthritis related to osteoporosis?
No.
That's
The osteoporosis does not hurt unless you break something.
Okay. I was told I couldn't use Forteo because I had radiation with my breast cancer treatment. Can you explain why?
Yeah, because Forteo treatment has been approved for 2 years only because it has been tested in animals, especially rats, where they used a very high dose, like 100 times the dose that's used in humans. And that showed slightly increased risk of bone tumors. And that's why if the bone has received radiation, that can also increase the risk of bone tumors. So that's why it's recommended to not use it in patients who had radiation to the bone.
I take UFM for urinary frequency. Will this affect my osteoporosis? UFM, yeah.
Yeah, I saw that in the chat, and it looks like it's a estrogen product. So you don't think that would affect the bones. Dr. Sharma, do you have any thoughts on that?
I mean, estrogen would actually help.
Yeah.
But if you're using local estrogen treatment, very little is absorbed into blood. But as far as I know, I don't think it should have any adverse effect on the bone.
How often should you have the bone density checked?
That's a good question. It's a hard question because it really depends on the individual, their history, family history. Usually I tell my patients who have osteopenia or osteoporosis, depending if they're on treatment or not, like 3 to 5 years. But if they have a normal bone density, a person can go 5 to 10 years without needing another one. It really is a very individual thing that everyone should discuss with their doctor.
Can you tell more about tooth loss when using some of the prescribed medications?
Tooth loss?
Tooth loss.
I mean, I'm not aware of an adverse effect of any of the medications that can cause tooth loss. So what patients are more worried about is called osteonecrosis of the jaw, which is where if the patients have been on treatment, especially with bisphosphonates for 4 years or longer, and they end up having some kind of surgery on their jawbone where it involves cutting off their jawbone, like putting implants, that healing can be delayed and part of the bone might become necrotic or sort of die, which is again extremely rare, and it occurs in less than 0.1% of the time. So I don't think there is, it's a major factor preventing you from treatment. So overall, the benefit of treatment is much, much higher than the small risk of jaw problems and things like that.
There's a follow-up question actually to the bone density test. When you should actually, the question is, when should you get the first bone density test?
Yeah, so we usually recommend for women starting at age 65 or older to start with their first one, and for men 70 and older. So ideally, in an ideal world, it would be 65 for, 65 and 70, but sometimes it doesn't work out that way.
Yeah, unless they have a risk factor that we showed on the slide, like being very thin and being on steroids and other drugs that can affect the bone. Yeah, then it's reasonable to check it sooner. Or if they already had a fragility fracture, like at age 55, they have a hip fracture from just slipping and falling. Yeah, that's a red flag. So then you would do bone density sooner. But majority of the time is what Janet mentioned.
There was a question of about the medications that you mentioned. Could you say more about the side effects of the medications you described? These seem like powerful systemic drugs which must have considerable side effects. Could you explain?
Yeah, I mean, all medications have side effects. So, but there are some that are common and some are very, very rare. So, for example, like I said, bisphosphonates like Fosamax or Actonel or Boniva, they can cause acid reflux, which is the most common side effect. And if that happens, then we switch them to the intravenous drug. Now, the rare side effect that patients are generally concerned about are, like I said, the osteonecrosis of the jaw or atypical femur fracture. And both of those occur with long-term treatment. And most patients have like other risk factors. So if you continue treatment for 10 years or longer, yeah, then the risk of the atypical femur fracture is higher. And if you have cancer or if you had repeated reclass treatment intravenously, yeah, that can increase your risk of the osteonecrosis of the jaw, again, with longer term treatment. So bottom line is, yeah, when you read about the side effects, they're very, very scary, but they happen in extremely rare situations. Overall, the benefit of preventing that major fracture is so much higher than the small risk of side effects that I would recommend treatment based on the data that we have.
Are there certain types of calcium supplements that are more effective than others?
I've heard from our endocrinology specialists, I know that one had described calcium citrate as being better absorbed in the body. It's a little more expensive than the calcium carbonate. Dr. Sharma, what do you think?
So, yeah, so the most common supplements are calcium carbonate and calcium citrate. So calcium carbonate needs acid in the stomach to absorb it. So if you're taking calcium carbonate, it's a good idea, like Tums, to take it right after a meal because there's more acid in the stomach. Whereas calcium citrate, sorry, is better absorbed on empty stomach. So if you're going to take calcium citrate, it's better to take it on empty stomach or in between meals for better absorption.
And how often should you have your vitamin D levels checked?
That's a good question because vitamin D is like the star, vitamin out there. Everyone says vitamin D can cure everything, but usually for my patients in primary care, I don't check it that often. Maybe, if they have risk factors, I may check it maybe every 2 to 3 years, but I usually for the routine, average risk person, I hardly check it, maybe once and then again, 5-10 years later. Dr. Sharma, what do you think?
Yeah, I think once the level is normal on replacement, and if they're taking the same replacement, unless they have gastrointestinal problems that came about, or they had gastric bypass surgery or something that would change their requirement, I don't see the need to check it ever.
Mm-hmm. So somebody asks about kyphosis. I'm concerned about kyphosis. Is there a treatment for it?
It's not really a treatment. I mean, it can indicate osteoporosis. Usually when the spine is starting to curve like that, there's not much that can be done, but certainly there are things that we can do to try to prevent some of the progression, depending on the history.
Right, exactly. So we cannot reverse it. I mean, if there is significant kyphosis, which is either causing lung problems or significant pain, then we would refer the patient to orthopedic surgery for evaluation to see if there's something surgically correctable. But most of the time, yeah, osteoporosis treatment does help prevent further progression of kyphosis.
This is about a reclassed injection. I had a very severe reaction to my first reclassed injection. What risks are there with the other injectable treatments?
So yeah, reclass can cause flu-like symptoms right after the infusion. And usually it goes away in a few days, maximum about 1 week. And the treatment is generally supportive, drink lots of liquids, take Tylenol or ibuprofen as needed. The good news is generally most patients who have bad reaction to the first reclass don't have as bad a reaction to subsequent reclass infusions. So just because you had bad reaction to one, not necessary to switch to something else. And so other drugs can have, so Prolia is another injectable, which is pretty well tolerated, doesn't have any significant side effects, unless if you have kidney problem, it may lower your calcium, so we always monitor that. And then Forteo or teriparatide is a daily injection. Again, it's pretty well tolerated. Sometimes it can increase the calcium, and some patients have nausea and headache or other symptoms. But by and large, these drugs are pretty well tolerated.
There were quite a few questions actually about yoga. And this one is here. I've been practicing yoga for 30 years. I've never had a fracture and recently have been diagnosed with osteoporosis in spine. And the level is 2.7, I think that's what it means. Is there any reason to discontinue any of my yoga practice? It keeps me strong and flexible.
I know at some of our osteoporosis meetings here at Kaiser, we've talked about certain exercises that can exacerbate things, I think have a higher risk of causing a fracture, kind of like the forward flexion movements. Dr. Sharma, do you have anything to add on that?
Yeah, I mean, exactly. I agree that, I mean, yoga is good for general bone muscle health, balance, things like that. But the extreme flexion is the one we try to tell the patients to avoid. And I think the Kaiser website also has information about what kind of exercises are good and bad for osteoporosis.
Somebody asked, how does calcium taken by mouth get to the bones? Is this reflected in calcium blood levels?
Not always. So just because your blood calcium is normal doesn't mean your bone has enough calcium, because sometimes, yeah, you are taking enough calcium, your blood calcium is normal, but you may be losing it in the urine. So that's why, depending on the individual patient, sometimes we check urine calcium to see if you're losing it. Because if the blood calcium looks normal, you're taking calcium, but your bones are getting worse, which would be an indication that we need to do further testing to see if the calcium balance is normal or not.
I'm 86 and have not taken any medication, though I do have osteoporosis. Would it be good to, I assume, start now? So,
yes, osteoporosis treatment has been shown to be effective irrespective of age, even in people in their 90s and 100s.
That's good. So why is alcohol an issue for osteoporosis, even if taken in moderation?
I think we said excessive amounts. Generally, we recommend not having more than 7 drinks a week for both men and women. We used to have a higher threshold for men to say 14 drinks a week, but now it's 7 drinks a week for both men and women. Beyond that, I think it's harder on the bones. But Dr. Sharma, did you want to add on to that?
Yeah, I mean, a lot of patients who drink excessively also have some nutritional deficiencies, and that can also be bad for bone health. But alcohol also has direct negative effects on the bones. So it's the excessive alcohol use that's bad for the bones.
Is lumbar stenosis a form of osteoporosis?
No.
Besides walking and running, which involve contact of the foot with the ground, what activities will help to reduce bone loss? For example, cycling, swimming, elliptical, cross trainer, Nordic track, etc. What do you recommend? Yeah,
walking is the best, because cycling, swimming, elliptical, these are not weight bearing, because yeah, they give you cardiovascular exercise, but they're not weight bearing. So even jogging is fine, it's weight bearing, but sometimes it's hard on the joints. So, but walking is best. So we generally recommend walking 30 minutes a day, which is a good exercise for the bones.
Mm-hmm. Well, with regard to this, I mean, somebody cites actually a work out of Australia shows that an 8-month program of high intensity resistance and impact training had a significant effect on increasing BMD in osteopenic and osteoporotic men and women compared to a control. Have you heard about this?
Yeah, I mean, intensive exercise can strengthen the bones as well as the muscles. But at the end of the day, we're not just looking for improvement in bone density, we're looking for fracture risk reduction. So what we're trying to do is to prevent a fracture. And so there's not enough data that even calcium and vitamin D by itself or exercise with calcium and vitamin D help reduce the fracture risk. So that's why when we see osteoporosis, when we see fractures, we recommend pharmacological treatment to prevent the patient from having another fracture.
Is it correct that we should not take iron and calcium at the same time? And please explain why and how long to separate taking them. Have you?
Both calcium and iron are poorly absorbed by themselves because they sit in the stomach for a long time before they get absorbed. So that's why if you combine the two, it'll take even longer for them to get absorbed. So that's why it's better to take them separately. As long as you separate them for 2 to 3 hours, I think it's fine.
On a side note here, from Ashby Village, actually, I just want to mention that Ashby Village will be offering a 10-week fall prevention workshop in the fall. Starts on September 20th and goes until November 15th. So if you're interested, please contact Ashby Village. So we have really a lot of questions about special treatments and medications, you know. Could you explain again how Prolia works and what it's useful for? Osteoporosis or osteopenia?
Right. So we generally don't treat osteopenia with medications unless you've had a fracture. So because when we have osteopenia, based on the clinical risk factors, we can calculate your fracture risk. And based on that, we make treatment recommendations. So Prolia also works on these osteoclasts that are chewing up the bone and stops them from chewing the bone and improves bone density and reduces fracture risk. In terms of efficacy, all these drugs have similar efficacy, and we don't know enough data about head-to-head comparison, but they all work to decrease the fracture risk by 30 to 50%. So generally, it's best to talk with your physician as to what's the best treatment for you. And just because something looks good on TV, it's not necessarily the best drug for you. So I think it's best to consult with your physician.
Are there disadvantages to taking more calcium than the dosage you mentioned?
Yes, actually, if you take too much, you can have a higher risk of kidney stones, for example. So I usually tell my patients in moderation, kind of stay within the recommended amount, try not to exceed that.
Mm-hmm. Does taking calcium have an adverse effect on your heart?
I mean, I would say the same, staying within the recommended amounts. No, there shouldn't be any effect on your heart. I think if a person has significant heart history and is concerned, they can certainly talk to their primary doctor, or the cardiologist can consult. But when I've talked to my patients who have cardiologists, usually the cardiologist is perfectly fine with them staying within the normal limits of calcium.
Mm-hmm. Well, in the same category, the question, what is your take on a recent study about the risk of calcification of the aorta from calcium supplements?
Yeah, I mean, I think it's a currently evolving issue. I know that, you know, we can check a person's coronary calcium score, for example, for someone who's at risk for heart disease. It's not a screening test that's done for everyone in looking for heart and looking at their heart health, but it is something that they could discuss with their doctor. Dr. Sharma, did you want to add anything about that?
Yeah, and I mean, we should know that just because there's calcium deposits in the aorta or in the coronary arteries doesn't mean that it's because of the calcium in the blood. So yeah, there's some data showing excessive calcium intake can increase your risk of calcium deposits in the blood vessels, but it's a part of normal aging process. Like a 70-year-old, even a 17-year-old will start to have some calcium deposits in their blood vessels, which just gets worse over time. And it has nothing to do with how much calcium you're taking or how much calcium is in the blood. So yeah, excessive calcium is to be avoided, but there isn't a direct correlation.
How often, no, can a person with osteoporosis have a hip replacement? I think that's kind of an interesting question.
Yeah.
Yeah, they should be able to.
Yeah, a lot of times when they have a hip fracture, they just get hip replacement, depending on where the fracture is. And we usually let the orthopedic surgeon decide that. But yeah, many patients get hip replacement for a hip fracture.
Are there any risks with dental work implants with osteoporosis? I understand that there's a slight risk of jaw necrosis with Fosamax and reclast.
Yeah, that's just what I mentioned, that, yeah, the risk is very small, but there is a risk. And usually the risk is if you've taken the drugs for 4 years or longer. If you've taken it for 1 or 2 years, it doesn't increase the risk. So, I mean, the current recommendation is if you're going to have implants and if you've been on the drug for 4 or 5 years, to stop it for at least 3 months before you do the implant. And these are the guidelines. There's no hard data to show that it's really helpful in preventing the osteonecrosis of the jaw, but that's something we tell our patients.
So this question came twice or even a lot more than that. I take Topamax for migraine prevention. Should I switch to a different medication? I'm concerned about its impact on my osteoporosis. So far, I've had no falls or bone breaks.
I mean, there are some medications that can increase the risk, as we discussed. So yeah, anticonvulsants or Topamax is one of them. Anti-seizure medication. Certainly there are some antidepressant medicines that can as well. I would probably suggest for that person to talk to their primary care doctor, maybe, could consult with a neurologist about alternative treatments, but I myself haven't seen a lot of neurologists taking Topamax off because of that. It depends on how much they're taking and how often they're taking it as well.
I think we're almost at the end of our time, but there's one question I find interesting. I've read that it's best to get one's calcium from food and not from pills. The National Osteoporosis Clinician's Guide, maybe. Anyhow, to what extent would either of you agree with this?
I like that. I like having my patients get it through their diet. I would say it's kind of hard to get the exact amount that you need. So sometimes taking a calcium supplement and in getting it in with your diet as well is a good habit. Dr. Sharma?
Yeah, I think if you can get it from the diet, that's better than the supplement.
And I think you all will receive a copy of Kaiser's vitamin and calcium D handout, and it has very good information about the amount of milligrams in certain food sources. So I think that'll be really good to look at.
Yeah, I think we are at the end of the time. I'm so sorry. I mean, there were so many questions. I mean, there are still I think over 100 still messages in the
Oh, wow.
box, So sorry that we couldn't get to all the questions, but I think we answered quite a few. And yeah, I want to say thank you again, Dr. Sharma, Dr. Lai, for answering all these questions and for this very interesting presentation. And I also thank the audience, to join us today, and hopefully you will join us again. And as you know, I mean, our presentations are free, but if you want to make a donation, please go to our chat box. I mean, you can see where you can do that. So yeah, again, thank you very much, and hope to see you all soon. And
Thank
yeah,
you.
one last thing, actually, that this presentation was recorded. So for people who want to listen to it again, it will be available by tomorrow, probably on our YouTube channel, on the Ashby Village YouTube channel. So thank you very much.
Thank you so
Thank you.
much.
Thank you,
Take
Sigrid.
care.
And thank you, Sigrid, for asking all those great questions. We had a lot of questions. Thank you, doctors.
Thank you.
Have a
Bye-bye.
great day. Bye.